we're going to take a quick trip through screening, brief intervention, and referral to treatment. This is an approach that has been strongly championed by SAMHSA and is being pretty widely implemented in primary care settings as a way of identifying folks who have risky substance use. They may not qualify for a full-fledged substance use disorder, but they're drinking more than is recommended or using more in the way of other substances than is recommended. And it's an attempt to intervene with them and help prevent them from continuing on progression to a substance use disorder. The definition of SBIRT is really involved in trying to take a comprehensive and integrated widespread approach to the delivery of early intervention and treatment services. And as I mentioned, it's really for people who are using at a level that confers some degree of risk. It can also pick up folks who have a full-blown substance use disorder and help to engage them in treatment. Brief intervention has really been shown to be effective for unhealthy alcohol use. It has not been shown so far to be effective for other substances. But I will talk about screening for those other substances because screening is useful in everybody. It's just whether the brief intervention component is effective or not that it's clear that it is effective for alcohol use disorder, but not clear that it's effective for other substances. How do I get rid of this bar across the top? Oh, there we go. In the past, before the SBIRT approach was widespread, interventions to address substance use disorders really focused on prevention and then on specialized treatment for people who met substance use disorder criteria. And the folks who had high-risk use really were pretty much not being provided with specific services. So SBIRT was designed to really be implemented in a primary care setting to pick up people who are using at a high-risk level. It is designed for use in a primary care setting. It's a little bit, takes a little bit of work to get it started, but then it can just pretty much be incorporated into regular routines for standard screening, such as checking vital signs. Brief interventions are low cost and, as I mentioned, effective for alcohol misuse. And the goal is to intervene early when someone's use is above recommended levels, but they haven't developed a full-blown substance use disorder. Core competencies within SBIRT are regarded as universal screening, asking everyone about use of substances, brief intervention, particularly for alcohol use disorder, to help people who are using at a risky level to identify that fact and to develop some other strategies to reduce their use. And then for folks who have a substance use disorder or who are unsuccessful in responding to just a brief intervention, to refer them to treatment or provide treatment directly in the primary care setting, which is, of course, our focus here in this ECHO program. This complicated slide may be useful as a reference after the fact. The main things to notice here are that the screening happens automatically with all patients. If there's a negative screen, nothing more needs to happen. If there's a positive screen, then the options are to have the patient complete a more extensive screen to gather more information, or go directly to interaction with the clinician. The clinician then needs to assess whether or not a diagnosis of unhealthy use is in fact present. So the screening is screening. The actual diagnosis is still relies on clinical assessment. And then if indeed unhealthy use is present, brief intervention is provided. Or if the patient has an actual substance use disorder, then a plan is made to manage to further provide services to that patient, which can include harm reduction, management of withdrawal, or engagement in actual treatment. A lot of sites use a sort of pre-screening strategy, short screens that can pick up potential problems and then be followed up with more intensive assessment. In general, using SBIRT in a primary care setting, 75% of screens will be negative, and about 25 will require further follow-up overall. So in thinking about pre-screening for alcohol, the question that's recommended is simply, do you sometimes drink beer, wine, or other alcoholic beverages? If the answer is no, you're done. You've done the pre-screen and you don't need to go on. If it's yes, then you move on to the NIAAA single item screener. How many times in the past year have you had 5 or more drinks in a single day? That's the number for men. For women, it's 4 or more drinks in a single day. Where did they come up with those? They really came up with those numbers from epidemiologic studies showing the amount of drinking that is correlated with adverse physical or behavioral health outcomes in the population. That if someone answers yes to that screener, it is has strong enough positive predictive value to suggest that you should then go on and do further assessment for unhealthy use. So you might find when you go on and do further assessment, you know, yes, I did that on New Year's Eve and I don't drink heavily ever otherwise, and then maybe you don't need to go further. On the other hand, the further evaluation may tell you that this person is drinking 4 or more drinks a day on a frequent basis, and that they're really drinking at an unhealthy level and need further intervention. So if you get a positive answer to that single item screener, you're then going to go on to assess the frequency and quantity of use on a weekly basis, or also assess for very heavy occasional use or binging. So for people who you find regularly exceed recommended limits or binge periodically, you're then going to go on to assess whether they have an alcohol use disorder. So looking at DSM criteria, this would include things, as you know, such as using more than intended or more frequently than intended, unsuccessful attempts to quit or cut back, interference with usual social or professional goals, such as interfering with your ability to carry out your job or be a parent, presence of withdrawal symptoms, presence of tolerance, etc. Turning now to thinking about assessment for use of other substances, again, you can start with a pre-screen. So your pre-screen may be how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons, such as for the feeling it caused. If the response is never, your screening is done. If the response is positive, you're going to go on to inquire further. And this screen has been shown to have a sensitivity of 100% if someone is answering honestly, and 74% specificity for a drug use disorder. You can then move on again to either a more extensive screen to assess further their drug use patterns, or you can move directly to clinical assessment, a clinical interview to assess their use. So in terms of key points for screening, it's recommended that we screen everyone. Everyone who's seen in a primary care setting is obviously at risk for unhealthy use of alcohol or other substances, and universal screening can pick up a lot of folks who you may not have developed any level of clinical concern about. It's recommended to use a validated tool, and if possible, incorporate this screening into other health screening in order to reduce stigma. It is important to explore each substance. If you get a positive pre-screen, to do a pretty careful cataloging of what substances patients are using, since, as we all know, co-occurring substance use disorders are common. And then to follow up positive screens with formal assessment for substance use disorder. And as always, motivational interviewing skills are our friend, because this is the main way that you're going to follow up on a positive screen is using motivational interviewing skills to encourage the patient to talk with you about the problem, and then to explore the patient's interest in or motivation to make a change if they have unhealthy behaviors. So I think I've already covered this. Down at the bottom of this slide, one thing that can be useful that we've talked about before in some of our case discussions is the use of the Readiness Ruler. So if you are detecting that the patient has use that exceeds recommended guidelines, you can use that Readiness Ruler to assess how prepared they are to really make a change in this. So after you've engaged in dialogue with them and used some of your motivational interviewing techniques to evoke motivation and promote change talk, you can then say, thinking about how ready you are to make a change in your alcohol use on a scale of 1 to 10, can you tell me where you fall on that scale? You know, maybe the patient says, I'm at a level of 6 in terms of my readiness to change. And then a follow-up question might be, tell me about why you're at a 6 and not at a 2 in terms of your readiness to change. Because again, that evokes the patients telling you about reasons why they're actually ready to make a change now, when you're asking them to compare it with a lower level of readiness. Let's talk a little bit about what to do if the patient expresses really very limited desire to make a change, or is frankly not super excited about the whole conversation. One strategy to use is kind of asking them to think more broadly about the situation, asking them to think down the line about whether they have concerns in the long run about the impact of their drinking, or if they can imagine with you what negative consequences might happen if they continue to use at this level or more. Another strategy with motivational interviewing is to really promote change talk, to sort of engage the patient in talking about why they might want to make a change. So let's say that we're talking with a patient who's drinking more than is considered healthy. It's ideal if you can identify some particular conditions that are tied to that. Let's say this is a patient who is seeing you for hypertension, and you learn through the screening that they're drinking more than is recommended. You might be talking with them about the link between hypertension and drinking more than is recommended, and then you could try to promote some change talk around that. So what might be a way that you might do that? Use motivational interviewing techniques to actually query the patient in a way, get them talking in a way that evokes change talk. Any thoughts about that? Go ahead, Laurel.
I think you have to figure out what is most important to them. Like for some of my patients, it's getting off a medication. And so it's, trying to figure out what it is that they want to, what would be most meaningful to them, and then work from that perspective. Well, if we change this, maybe we could decrease this or get you off this or do something from that perspective. Yeah. I mean, that's what I try. That's how I try to work things. Maybe we can, that, I don't know.
Yeah, I like that. And anybody else want to add to that or have an additional suggestion or thought? Sherry, you're muted if you're trying to talk to us. I'm not sure if you are.
I wish we could do it on the screen. There'll be a lot of times people have motivation during pregnancy, they don't have for themselves outside of pregnancy.
Uh-huh.
So when it comes to, alcohol, drug use, and actually cigarette use as well, it's, the idea is that it's a window which will have some motivation they don't have normally. So you just kind of talk about the benefits to the baby, but also the benefits to them long term as well, because they have a window where they actually are motivated to make change for the baby, where they may not feel motivated normally.
Great. Yeah, that's terrific. Any thoughts about how you would promote change talk in talking with a patient who's pregnant and drinking, more than you think is appropriate, which is probably much at all?
Well, I think that we often will talk about, what can you do in general for a healthy pregnancy, a healthy baby.
Right.
And you may start off with generalized things like, diet and vitamins, and then narrow in on specific things like, the alcohol and how its association with fetal alcohol syndrome, what that means, and the opiates in association with neonatal abstinence syndrome, and how, and kind of their motivation towards trying to make this baby as healthy as possible. And so a lot of times we'll start off just talking about general health, and then also more specifically, the issues which are involved.
Mm-hmm. So it sounds like maybe asking something like, what are things that you think you could do to have the best possible outcomes for your baby, or the healthiest pregnancy possible? And then prompting around alcohol if she doesn't go there, or around cigarette smoking. Is that right?
Right.
Yeah.
Exactly.
Good.
What
other
are the concerns of the pregnancy?
Yeah, great. Other people want to chime in?
A lot of times, one way that we'll talk about it with patients is we'll have patients that are engaged in psychiatric medication management, and they're also using alcohol.
Uh-huh.
And we identify that discrepancy and kind of work in that ambivalence, and talk with them about, it sounds like you're using alcohol in an effort to try and manage your symptoms of anxiety, depression, trauma, etc. And with that, it's really hit or miss in terms of how you're able to manage your symptoms with that. Your medications, however, are designed and being prescribed in an effort to successfully medicate those things for you. So kind of help me understand how the alcohol use is at this point outweighing the benefit of maybe trying out some of these prescribed medications that in the past have worked really well for you.
Okay. Angela or Adam, do either of you want to chime in with any thoughts, suggestions?
I like the suggestions so far. Angie, anything to add?
Yeah, I mean, I would ditto everything everyone said. For me, one of the most important things is pulling from the patient's narrative. Sometimes if I find myself where a lot of sustained talk is happening, I might try to pull up a chair where they are next to them and ask them to share with me some of the positives before we move into some of their concerns about the future. And sometimes after you do that, pull up a chair next to them where they are and why they want to continue before you move into some of the reasons to stop. It brings out some more of that narrative so you can hang on to that change talk from their narrative.
Mm-hmm. I love the suggestion of physically pulling up a chair next to them and sitting next to them, literally as well as figuratively. That's great. Great. Maybe one last comment. Mariah, were you trying to unmute?
Yeah, I just thought I would put in there how important it is to quantify what they're doing, because then, of course, people sometimes surprise us and make a lot of progress. So it's good to know either way if the use is more frequent, less frequent, or increasing, decreasing.
Great. I like that.
Think it's a really important element of the history.
Yeah, because if someone comes back and you ask, are they drinking more or less, it really is helpful if you have quantified how much they were drinking before and how much they're drinking now, so that you have another kind of a marker. That's excellent. Okay. So we're all familiar, I think, with this concept of rolling with resistance. I think this term is not so much being used in teaching motivational interviewing now, but it still can be a helpful way of framing it to ourselves. When someone isn't in tune with making a change, it can be very tempting to go into our lecturing and explaining mode. And it's pretty clear that that's not likely to result in the patient suddenly seeing the light and agreeing to do what we think they should do. It's much more likely to create resentment, resistance, them telling us the reasons why we're wrong and their approach is right. So this can be a good opportunity to ally with the patient, to reflect what you're hearing them say about why this is important to them, and in particular to make it clear that you recognize that it is their choice, that nothing you can say or do is going to make them change their behavior. They have to decide what is best for them and what choice they want to go with. Yeah, these are things, just some additional pointers in using motivational interviewing techniques when you detect some readiness, some hint that the patient is thinking about making a change. Opening things up and having an attitude of curiosity. Questions such as, if you were going to be completely successful making the changes you're talking about, how would things be different for you? Just allowing the patient an opportunity to really use their imagination and expand on what the impact of that would be in their life. If you get to the point where the patient is actually ready to move into the action stage, it can be helpful to work with them around a very specific and particular plan, such as the patient says, I think I'll try going to an AA meeting, then maybe working with them on, okay, what meeting, what date, where can I help you to find a specific meeting that you're going to attend, and problem solving with them around if they don't have a ride, how can you help make it really feasible to do what they're talking about doing. If someone says, I'm prepared to go to counseling, jumping on that willingness and openness to make a specific plan and helping them to turn that into reality and have an actual plan for who they're going to meet with and when. A treatment plan can obviously include a lot of different elements. Medication treatment is ideally provided in the primary care office in order to promote adherence and reduce stigma. It's important to think about what's culturally appropriate for the patient. Do they have a particular set of cultural beliefs that are going to make one type of treatment more acceptable than another, one treatment setting more acceptable than another? Are there elements of their culturally defined beliefs in what will be helpful for treatment that you can weave into things that might not be familiar to them, but that you're recommending that they participate in? Self-help groups and peer support are extremely helpful for a lot of patients, and thinking about the kinds of lifestyle changes that can really help promote recovery, such as diet, exercise, and meditation. And finally, formal counseling and psychosocial rehab programs can be very, very helpful. Last point is just to think about if you think specialty treatment is needed. There are various different types of treatment setting, and thinking through those before you make a referral can be very helpful. The ASAM criteria help to guide that based on the severity of the patient's substance use disorder, co-occurring disorders, their home environment, potential for self-harm, etc. So thinking about inpatient treatment, which is most appropriate for very severe and complex substance use disorders, often with co-occurring disorders, residential options, and then outpatient care. And outpatient services are where most people are going to get their treatment, and primary care, as you all are engaged in, is a great place for that I think I'll stop there. Just wanted to point out SAMHSA has a National Treatment Facility Locator online that can help if you're looking for inpatient or rehab programs. That can be a really helpful resource. So